Hi, so welcome everyone. I'm Kathy Refshauge. I'm Professor of Allied Health at Sydney University and I'm today's MC. And I honestly can't tell you just how excited I am to welcome you all to this, our second forum focused specifically on allied health. It's a shame in a way it's online because we can't see you all. But on the other hand, it's so much more accessible. So we've gone ahead online again this year. But before we begin, I'd like to begin by acknowledging the traditional custodians of the many lands upon which we meet today. I acknowledge the Gadigal and Biribirigal people from the Eora Nation, because that's where I'm located. The Indigenous peoples of Australia were the nation's first scientists, and I pay respects to them, to elders past and present, and I also acknowledge any Aboriginal or Torres Strait Islander peoples who are joining us today. Now, I've got great pleasure in introducing Professor Ingrid Scheffer, the Academy's president. We're very fortunate that Ingrid's here. She's a physician-scientist whose work as a paediatric neurologist at the University of Melbourne and the Florey Institute has truly led the field of epilepsy genetics for more than 20 years. Ingrid and her colleagues were responsible for identifying the first epilepsy gene and many more genes subsequently. She's described many novel epilepsy syndromes and she's performed genotype-phenotype correlations. Ingrid's contribution has been recognised by her many contributions have been recognised through numerous honours and awards, including an Order of Australia in 2014 and also the 2014 Prime Minister's Prize for Science. Ingrid is also a founding fellow of the Australian Academy of Health and Medical Sciences and has been president since 2019. So I have great pleasure in inviting Ingrid to say a few words to you all.
Thank you very much, Kathy, and thank you and your organising committee for arranging this event. And I'd like to also thank the attendees for giving up their time to be inspired, to see just what wonderful things you can do as a clinician scientist. I just wanted to introduce the Academy to you briefly. And the Academy is the nation's learned academy for the health and medical sciences. We provide an impartial, authoritative, cross-sector voice of health and medical science in Australia, and we are an interdisciplinary independent body of 451 fellows. These individuals have been elected by their peers for their outstanding achievements and exceptional contributions to health and medical science in Australia. The Academy is uniquely positioned to convene cross-sector stakeholders from across Australia to address the most pressing health challenges that face society. So what does the Academy do? Well, we have a number of different roles. The first is to influence policy and provide independent expert advice on pressing challenges, enabling decisions by government, industry, and the community to be informed by the best available evidence. We celebrate excellence in Australian health and medical sciences, and we do this by promoting an active fellowship of Australia's leading researchers and leaders in our community to reflect the full diversity of health and medical sciences. We support Indigenous health and wellbeing by working actively to improve Indigenous health and wellbeing and the representation of researchers of Aboriginal and or Torres Strait Islander descent. And the final major strategic objective is about today, and that is to nurture talented research leaders. And we need to cultivate an environment in Australia in which future health and medical science research leaders can thrive. And we want to inspire you to think about a career as a clinician scientist, whether that be in physiotherapy, occupational therapy, speech pathology, psychology, nursing, midwifery, any domain within clinical care. So I'm very attached to these events, Life as a Clinician Scientist. I started the first one, I think, 7 years ago now, and the first really 5 years until last year were focused on junior medical doctors. But now I'm really excited that we've expanded it to allied health and nursing and midwifery, because there's a huge need for clinician scientists across these domains. And there's no better way to be inspired than to see those ahead of you and hear about their career paths and hear about what went right, but also, just as importantly, what went wrong. Because I think it's important to know that we all have a fair bit of serendipity in our career paths. It's about taking the opportunities that present themselves in your career, and they may not be what you plan, maybe something you don't plan, but it may turn out to be even better. And whatever happens, life as a clinician scientist is super exciting and really very fulfilling through the whole of your life. So I'm going to leave it there and hand back to Kathy. Thanks, Kathy.
Fabulous. Thank you, Ingrid. And how true is that? It hardly ever goes according to plan. So now I'll introduce this session and just say a few words. And I'll build on what I said last year, that this is the beginning of allied health really taking off, becoming more visible, having many more allied health clinician scientists. And quite a bit has actually happened since last year. And I would love to take credit for that, not me personally, but the Life as a Clinician Scientist seminar series. But it's very exciting, and we want to hear more about it. So today we're going to hear more about how to make those changes happen and how to actually get started. Based on the feedback from last year's event, it seemed that people wanted to know more about the how-to. So how to get started as a clinician scientist and how to create a workplace that supports clinicians engaging in research. So we've chosen presenters who can talk about exactly that. They'll share their stories about getting started or creating pathways for allied health clinician researchers. And they won't be giving you the sanitized version, you know, where everything goes exactly according to plan. They'll do exactly what Ingrid was talking about, the real version about the painful barriers and no doubt some failures here and there on the way, but also those exhilarating highs where you really know you're making a difference and having a massive impact. So you'll hear about how to get started from Lauren Christie, an early career researcher. In fact, she's just been awarded her PhD, and also some successful initiatives that have been established by the visionary, strategic, energetic, and incredibly smart allied health managers and leaders that will be talking today: Nick Taylor, Sue Berney, Anne-Marie Boxall, and Vin Cavalheri. So this webinar is primarily a showcase about how allied health professionals have made these opportunities, exploring both the exciting and difficult aspects of the path. But most importantly, we've set aside plenty of time at the end for questions and ideas from all of you. So it gives us a chance as well to seek your input into how to make these opportunities more available in your own workplace. So a couple of words about asking questions. We will start the short talks, and there will be time potentially for questions after each talk, but there is a panel discussion where most of the questions will be asked. So if you could use the chat function to ask the questions, just type them into the chat box, which should be on the right of the video in the web streaming platform. And you can actually open it as a separate window if you want to. The other thing is you can vote for questions that someone has already asked. And so just like it, just as you would a thumbs up, like you would in any other social media platform. And that'll raise it up and elevate it to a more important question that we'll ask. And the other thing, it would be great if you want to join the discussion on Twitter. So you can follow the hashtag, use hashtag at the hashtag, sorry, Allied Health LACS, or one word, Allied Health Life as a Clinician Scientist, and also copy in the Academy using the at AHMS, AAHMS_health, so that you copying in and we can all retweet it. So I now have great pleasure in inviting our first speaker, Dr. Lauren Christie. Lauren is an occupational therapist. She's a clinician researcher and the Senior Implementation Science Research Fellow in Allied Health for St Vincent's Health Network in Sydney. Dr. Christie's PhD studies focused on clinician behaviour change in stroke and traumatic brain injury rehabilitation using implementation science methods. The title of Lauren's talk is Walking the Tightrope as a Clinician Scientist. So thank you, Lauren.
Thank you very much, Kathy, and thank you to the Academy for the opportunity to present to you all today. My journey as a clinician scientist started way back in 2009. As Kathy has mentioned, I'm an occupational therapist, and a couple of years out of university, I was working on the stroke unit at Bankstown Hospital in southwestern Sydney. In my time there, we'd started a program to target dressing retraining practice after stroke at a time when our staffing levels were low, as a way of ensuring people were getting some regular activities of daily living retraining in line with the National Stroke Guidelines. The unit had a strong culture of research at the time. Carl Scher and Dr. Simone Dorsch, who you may know as research active physiotherapists, were senior clinicians on the unit at the time, and Dr. Kate Scrivener, another physiotherapist, was completing her PhD studies part-time on the unit. As a rather green clinician with a lot of curiosity and having found my passion for stroke rehabilitation, I came to the conclusion that in order to become the best clinician I could be, engaging in research would be a really great step forward. At the time, an academic, Dr. Annie McCluskey, who's also an occupational therapist, was regularly visiting the unit and heard about our quality improvement project over lunch one day. She advised myself and a colleague that there'd been limited research published in the area, and would we consider further developing our QI project into a small research study. That study resulted in my first peer-reviewed publication and the opportunity to present at national conferences. I was then offered the opportunity to do my master's by research on the same topic, but instead decided to pursue a long-held dream of working and travelling overseas, so ran away for a little bit. Upon returning to Australia 3 years later, after working in both the public and private healthcare sectors in the United Kingdom, and still with a keen interest in research, I commenced my Masters by Research part-time through the University of Sydney in 2015, whilst working in a full-time clinical role as the Inpatient Program Coordinator at Liverpool Hospital Brain Injury Rehabilitation Unit. My topic for my research within my master's degree was focused on constraint-induced movement therapy, or CIMT, a proven effective intervention for arm recovery after stroke and traumatic brain injury that's strongly recommended in our national stroke guidelines, but not routinely offered in practice due to a range of therapist, resource and patient-related barriers. And whilst working overseas in the private sector with greater flexibility in funding models, I'd been able to offer this intervention more regularly and seen some excellent clinical outcomes. So I was interested in how I could translate that into my work in Sydney within a public health setting. In 2016, I applied for and was successful in receiving a New South Wales Health Translational Research Grant to conduct an implementation study across 9 neurological rehabilitation teams at 5 hospitals in southwestern Sydney Local Health District, called the Active Arm Study. This funding allowed me to reduce my clinical role at the brain injury unit to 3 days a week with funding for backfill, and to work as the principal investigator and project coordinator on Active Arm 2 days a week for a 2.5-year period. Active Arm was comprised of 4 studies and built on earlier work within my Masters by Research program, which had explored the factors that had supported clinicians internationally to successfully implement and sustain CIMT programs over time. ActiveArm provided me with the opportunity to upgrade to a PhD program of research. I designed, then tested a behaviour change intervention to help support occupational therapists, physiotherapists, and allied health assistants to change their practice and deliver CIMT programs more routinely within usual care and existing resources. ActiveArm also explored participants' experiences of receiving a CIMT program and an economic evaluation of the cost effectiveness of CIMT implementation. ActiveArm resulted in over a 50% increase in the proportion of eligible stroke survivors and people with brain injury who were offered and received this evidence-based intervention. And these changes in practice were sustained 6 months after withdrawal of our implementation support. Following completion of ActiveArm and returning to my full-time clinical work, I missed having the opportunity to wear both my clinical and research hats. I was notified by an external mentor that a full-time allied health research role had become available at St. Vincent's Hospital, and I was successful in obtaining that role and transitioning to my current position in late 2019, where I support other frontline allied health clinicians to engage in research and with a focus on increasing allied health research capacity. In focusing on the benefits of having a culture that supports allied health clinician-scientists, I wanted to share with you some of the outcomes that we achieved through ActiveArm. From that project, that single project, we achieved a range of successes that go far beyond simply the research outputs. Using the translational research grant funding, I was able to employ an occupational therapist and physiotherapist part-time as research assistants who had an interest in research. Both of those clinicians are now enrolled in postgraduate research degrees and also remain clinically engaged. So ActiveArm provided the opportunity for us to increase our allied health clinician scientist workforce capacity. We were also able to upskill 9 teams across 5 hospitals in research processes, from consenting participants to assessment and delivery of interventions and supporting data collection. We now have an upskilled workforce across southwestern Sydney who were not only research engaged, but will be ready to take on future projects. And I'm now mentoring one of these staff members who's recently commenced in his first role as a part-time clinician scientist. For myself individually, it improved my skills as a clinician. I now feel like I'm a much better clinician than I was before I started my research degree. I'm able to appraise evidence. I'm better at selecting the right intervention for the right person at the right time. And I'm also better able to provide education to patients about what their options are in terms of interventions and the likely benefits of those. Finally, and most importantly, were the benefits for patient outcomes. Patients at the participating sites within ActiveArm now receive a strongly recommended evidence-based intervention that was difficult to access before, and they achieve both statistically significant and clinically important improvements in their arm function and performance in occupations. In terms of the challenges as a clinician scientist within allied health, one of the biggest challenges was balancing 2 very busy jobs, both my role, my clinical leadership role within the brain injury unit and my research role with ActiveArm. Both of them could have been full-time jobs in their own right. And so fitting both in the space of one position was at times challenging. It can also feel quite isolating at times being a clinician scientist. You don't really fit in with the students who are studying full-time, and there's less opportunities for you to engage with other research students because you are working in a frontline clinical role. Within your clinical role, it also sometimes means that you feel that depending on the culture within your team, that the research is somehow seen as quite separate from your day-to-day job as an extra thing that you do. And that in and of itself can feel quite isolating at times. There's also a real lack of roles and opportunities for career progression for allied health clinician scientists like myself who wish to remain embedded within the health service and to use their clinical expertise whilst also conducting high quality research. For myself, I'm grateful for the opportunity to now work in my full-time research role at St Vincent's, where I'm supported to pursue ongoing research in my areas of interest in stroke and TBI rehabilitation. However, my current role doesn't have a clinical service delivery component. So I've maintained my engagement in clinical work through continuing to work on a casual basis as an occupational therapist at Liverpool Hospital and contributing to external teaching. The options for me were limited at the time of heading towards the end of my PhD. I could continue on a clinical leadership or management role track or move to academia, when in fact I really wanted to have the melding of those two positions. So I think in particular, we need to look at models for embedding clinician researchers within health services, particularly in the field of research where I work in implementation and knowledge translation. Frontline clinicians are best placed to tell us what will work and what won't work, and how to integrate research into existing care pathways. And I think we can learn a great deal from conjoint academic position models like those used in medicine around ways we can best support staff to achieve that outcome. We also know that research active health services have better outcomes. So looking for opportunities to build on that to maintain an engaged workforce is also really important. In terms of enablers and strategies that help to support me in undertaking research whilst working as a clinician-scientist, completing my research degree has been the most rewarding experience of my professional career. Not only have I learnt a whole lot of new skills, it's fed my curiosity, and I've had the opportunity to challenge myself and also to work with some incredible people. Having protected time to work on research is incredibly helpful. So I would encourage any of you with an interest in research to look for opportunities for funding, both big or small, that allow you to buy out some of your clinical time to be protected to undertake research, and for managers to be able to backfill your clinical position, because it can make a big difference in terms of your study progression. Small pockets of money, whether it be through internal funding opportunities at your health service or external larger funding bodies like New South Wales Health or other statewide organisations or national funding bodies, can also help with things like research assistant support, hiring by a statistical consultant support, and also would encourage you to look at opportunities for student engagement with honours programs to help you with some of your smaller project ideas. Another really important component was having advocates and support within management. My frontline director was incredibly supportive, Matt Jennings, the Director of Allied Health at Liverpool Hospital. He helped me to develop networks as well as gain support from a number of the sites involved within Active Arm. It's also useful to develop your networks with other clinician researchers, because they can be a really great support network for the times when the study can be quite challenging. For me, this involved developing networks with other occupational therapy clinician researchers who are based in Melbourne, who work in a similar field at Alfred Health, and who are now my ongoing research colleagues and friends. I think having a supportive supervision team is also critical, and I'm really grateful for my 3 amazing academic supervisors who supported me throughout my research journey. And also look at opportunities for having external mentorship if you think it would be useful. I have external mentors both within my discipline as well as in other disciplines, including medicine, and they really help to build my ideas, to challenge me, and to provide new perspectives in my research journey. So in terms of take-home messages, for those of you who are considering dipping your toe within research, the most important thing I would say is I would really encourage you to go for it. Look for opportunities to really just start to get a feel for research. That might be assisting with data collection within a larger study, even if you aren't running the project yourself, or considering enrolling in a postgraduate degree. I think it's really important, though, to select a research topic that's relevant to you. It's a question that you're going to be looking at for quite a while, whether you're doing your studies on a part-time or full-time basis. So ensuring your question is relevant and meaningful to you, your practice, and most importantly, the patients you see every day is really important to help you maintain motivation at the times when things get hard. As I've said, make sure that you look for opportunities to develop a support network, and always remember research is a team sport. I attribute a lot of the success of Active Arm to working within a great team, and that included other allied health clinician researchers, Reem Rendell and Nicola Fern, who worked with me as research assistants on the study, as well as having advocates and supports within the broader allied health management team across Southwestern Sydney Local Health District. So in closing, I would encourage all of you who have an interest in research to go for it. Your first step might have been enrolling in this webinar, but you never know where the road might take you. Thanks very much.
Thank you, Lauren. It's a shame that you can't hear all the clapping, but that was fabulous. And I love that you're talking about this, such a much better clinician having engaged in research like that, and the impressive amount of influence you've had already, supported by the wonderful Matt Jennings. There are a few questions for you, Lauren, but we'll hold them over to the end, if that's okay. So don't forget what you've done in your life, because it will come back to us. So now I'm delighted to introduce Professor Nicholas Taylor. So Nick is a professor of allied health, which is a joint appointment between La Trobe University and Eastern Health. Nick's research focuses on improving rehabilitation outcomes by evaluating exercise and physical activity interventions and investigating the best way to deliver health services in rehabilitation. But he's going to talk about this fabulous program that he's been one of the instrumental people in establishing. And the title of Nick's talk is Stepping into Research, as you can see here, Stepping into Research in Allied Health. Thank you, Nick.
Thanks, Kathy, for that introduction, and thank you to the Academy for the invitation to speak. So I'm going to share 3 short stories about how I stepped into research, and then I'm going to talk a bit about the messages which I think arise from those stories. So it starts a while back in the early 1980s, when I was a young physiotherapist. I was working in a general hospital on a medical ward rotation, and I think I had a bit of an existential crisis because I was there with a patient with a pulmonary condition. Airways clearance is really important for these patients. And at that stage, one of the techniques we used was called percussion. What it really involved was standing there and hitting people on their chest wall. And you might be thinking, why would you do that? Well, because at the time, I think I remember thinking really vividly, what is the point? Why am I doing this? I don't buy the rationale that bashing someone on their chest wall can help to loosen secretions inside their lungs to make it easier for them to clear them. I thought, I've got to do something. I've either got to leave this profession that I'm just joining, or I've really got to ask some questions about what works and what doesn't work. So essentially, I was asking a question about, is percussion a worthwhile technique to help clear airways in people with pulmonary conditions? There's been a body of work which essentially in systematic reviews which says that generally it doesn't seem to make much difference, and it's not my area, and I know there are people on the panel who've got content expertise, but my understanding is it's a technique that is now rarely, if ever, used, but maybe they can correct me on that. But I guess it was a pivotal moment because it really made me think about questioning what we do in our practice as an allied health clinician. My second story is about my first paper, my first publication. And this is when I was working as a clinician, again, in a hospital in the outpatient department. And at that stage, when I collected the data for the study in the late 1980s, the leaders in the physiotherapy profession, the ones who'd done further qualifications at that stage, and the leaders were people who'd done postgraduate training in manual therapy. And it was kind of like, it was seen as almost the pinnacle of the career, and it was seen to be the most prestigious part of practice, was doing manual therapy techniques which required skill and backed up by a whole body of theory. So, and I sort of thought that was so, because in my practice, I seemed to have patients when I attribute them getting better due to my superior manual handling skills. So I set out to investigate that as a clinician, just on my own and in a hospital. And I was really asking, does passive joint mobilisation aid return of active movement of the wrist following cast removal after Colles fracture, that is wrist fracture? And so it was done as a controlled trial, and we're looking at comparing exercise advice and passive joint mobilising compared to the comparison group who got exercise advice and an equivalent time period spent of soft tissue massage. Now, I do remember vividly that the senior in my department refused to be a therapist in this study because she said she wasn't going to waste time holding hands with patients for 5 minutes who'd been allocated to the comparison group. Anyway, what did we find in that study? We found it was set up as a superiority trial. I was sort of hypothesizing that the people getting manual therapy would go better, and this would be a really good way to tell others about the benefits of this physiotherapy technique. What we found was that, in fact, there was absolutely no difference between the groups. So certainly routinely doing passive joint mobilising for people recovering from Colles fracture made no difference compared to doing soft tissue massage. That was sort of interesting because, and it showed to me at the time, the power of research, because it was really powerful to me because it changed my view. I was really sold on the benefits of manual therapy. Even when I was doing joint interventions, I thought it was the manual therapy that was working. And this, to me, changed my view that perhaps it wasn't. Perhaps that technique alone isn't enough to make adaptive changes to tissues. The other thing, a couple of other things about that first paper was that when I presented it at a department meeting, afterwards, a senior academic in manual therapy came up to me and said, "This must never be published," because it could be seen to be negative to the profession. And I had a real reaction to that. I thought, that is just so wrong. And it helped get me over my procrastination and getting to the stage of getting it published, and eventually did get published. And the other thing that those of you with an eagle eye might see is that my co-author was Kim Bernell, who at that stage was a clinician. This before Kim had gone into research. And for those you know now, Kim is a stellar researcher with an international career, internationally acknowledged for her work in osteoarthritis. So I worked with Kim to get to the stage of getting it published. So that's my second story. My third story, fast forwarding to the 2000s, still a fair while ago, isn't it? Here, that's me back in the 2000s, a little bit younger, still no hair. And this is Karen Dodd. This is 2000s. This is at the stage after I'd enrolled and completed a PhD. And Karen, who was a paediatric, at this stage I was working at the university as a tutor, a junior lecturer. And Karen Dodd, who's the paediatrics lecturer in our department, had also recently completed her PhD. Anyway, we were having coffee one day and Karen was just talking about her area and paediatrics. And she's saying, it really annoys me how we're told that for young people with cerebral palsy, you shouldn't do resistance training because it'll increase their spasticity. She said, I don't know that I've ever seen any evidence, but it's like this shibboleth, something we're told is really important. So just from that coffee conversation, and we said, well, why don't we look into it? So we agreed that we do a systematic review. And I guess our overall question for our research for that review and what followed is, what is the effect of resistance exercise on activity in young people with cerebral palsy? And from that coffee conversation, that collaboration led to 36 joint author publications, 3 PhD completions, and the first NH&MRC project grant that had been awarded in my department, in my university. And perhaps it also contributed to, that body of work contributed a little bit to knowledge and a little bit to change of practice. And certainly it might have contributed a little bit to the idea, debunking the idea that people with neurological conditions shouldn't do resistance training. The other thing too, I do remember about the NH&MRC project grant, which was a natural sort of culmination of our body of work that we were working on that. And a senior colleague said to me, what are you working on that for? You know you'll never get funded. So it was just interesting. So I was kind of, and sometimes, and it was just kind of really interesting that didn't put me off. So they're my 3 stories. What are the 3 messages arising from those stories? I think the first one is that it always comes back to the question in research. And you might have noticed that on each of my stories, I had a color-coded slide about the question, which about the population, the intervention, and the outcome. So we're all familiar with the PICO format. It's a way of sort of guiding us to clarify our research question, in this case for intervention studies. And I think it's so important. In my current role as Professor of Allied Health, and I'm talking to clinicians who've got a research idea, what the discussion always comes down to is clarifying what the research question is and making sure you've got a question and you're passionate about asking a question and finding out the answer and being clear about what the question is. So the question, really important. Second key message is the importance of collaboration and building relationships in your research. So here I am pictured with some of the people I work with at the moment at Eastern Health, Amy Dennett, Kathryn Harding, and Annie Lewis. And one of the things that's about collaboration and working together with others is that it's fun. We kind of look happy there. So enjoy working with each other, but also more importantly, that the sum with working with people who you like working with, the sum is greater than the parts. So I think the collaboration is really important. There is a flip side to that too. I remember years ago going to a presentation from an OT researcher from America who was towards the end of her career. And her take, the one thing I remember her saying was the one thing, in a broad American accent, the one thing she learned in her research career was not to work with icky people. So I think collaboration is really important. And the third message is about having a clear vision. So that sort of sounds straightforward, but I think what I mean by that is it's important to stick to your guns. If you're really clear about what your research question and what you're aiming to do, then don't get spooked by naysayers. Really stick to your guns. And I talked about the example, for example, this person who said, you'll never get funded, or the person who said, this must never be published. And thankfully at those stages, I had, I kind of knew that was wrong, and I had a clear vision about what I wanted to do. There's another part of that though, about this is not getting spooked by people external to you. I think also important not to get spooked from your internal voice. Even this morning, if I can share a fourth story, this morning I got a review back from a systematic review that I've been working on with a student. And the review was, it was a bit critical, major revision, so the door's still open, so that's good. But the review was essentially questioning some of the research methods of the systematic review. And I've published a lot of systematic reviews. I teach systematic review courses. And there was a little voice in my side of my head, which has been going through last night and this morning saying, maybe you're not really up to it. Maybe you don't know what you're doing. And, I think we all have that sort of internal voice sometimes. And it's important to see it for what it is. And this is not to, the feedback we got in the review is important. You don't ignore it. take it on board, and we're going to think about how we can make our systematic review better, but not to get spooked by that. And so not to get spooked by people too external to you, and also by your own internal voice. So my three messages are: have a clear question, make sure that you collaborate. Coffee is important. Good researchers are never too busy to have coffee, to chat, and things just happen when you have coffee that are important for research. And also stick to your guns and have a clear vision. Thank you.
Wonderful. Thank you, Nick. There's so many stories there for people to work with, and very relatable. And that the serendipity, I mean, it's a shame. You can't really be a researcher if you don't drink coffee, right? But those serendipitous conversations are really magic. And the thing about don't work with icky people is a wonderful piece of advice. In fact, to work with someone, I think there's a criterion in position descriptions about be nice, and not listening to that internal voice when it's being a bit of a naysayer. But Nick, thank you very much, and we'll hold the questions until the panel. But very wise talk. Thank you. So now I have great pleasure in introducing, we're going to have the panel now, but Dr. Anne-Marie Boxall, Professor Sue Berney, and Associate Professor Vinicius Cavalheri will actually be saying a few words about their work and the strategies and initiatives that they've rolled out tried to in their workplace that have really made a difference in the research environment. So Dr. Anne-Marie Boxall, and I hope you all know Anne-Marie because she's the Australian Government's Chief Allied Health Officer. She trained as a physiotherapist, or was educated as a physiotherapist, and has worked in the public and private sectors. For more than a decade, Dr. Boxall has worked in high-level policy roles in the Australian Public Service and for non-government organisations. Her role as Chief Allied Health Officer includes supporting the Australian Government's primary healthcare 10-year plan and workforce reforms. And please know that Anne-Marie is our first ever full-time Chief Allied Health Officer. So she's much respected and very valued and very welcome. So Anne-Marie.
Thank you very much, Kathy. And I'm not sure if I'm visible because I'm completely blacked out on my screen, but I do have my video on. It's possibly my iPad, which is old, and I'm not quite sure what I can do. So maybe I should just proceed, Kathy, because
yeah, just proceed. If you don't have any slides and things, then go for it. Just proceed.
Yeah. Okay, great. I don't have any slides, so I'm sorry that no one can see me. This randomly happens with my iPad. So look, again, thank you very much for the opportunity to speak with this group today. I will just address you can't be a researcher without drinking coffee, because I am still an active researcher and I don't drink coffee. However, I do drink a lot of tea. So I think that kind of covers the bill there. So look, what I wanted to talk to you today about was how allied health clinicians and researchers can influence national health policy. So my role in the Commonwealth Government it's a fantastic role, but it is very different from, I think, what most people are doing. But I did really want to take this opportunity to encourage people to think about how their research and their clinical practice can have an influence at the national level. The beauty about working at the national level is when you make a change, you affect a large number of Australians. So you can have a huge impact. The challenge is that it's much harder to do. But I just wanted to sort of put that challenge on the table and encourage people. So just a few, I guess, piece of advice for people that are interested in influencing national health policy. So the very first thing I say to people is you need to follow the national health policy debates and the agenda. So that sounds simple, but it's probably a little bit harder than you think. So at the moment, we're obviously in the middle of an election campaign, and there are a lot of discussions going on, some of which are about health policy. And so that's a great opportunity to follow the debate. But when we're out of an election campaign, things like subscribing to the Minister of Health's press releases. So that gives you a really good idea of what matters to the government and what matters in health. There are a lot of communications that come out from the Commonwealth Department of Health, and that's another great way of finding out what the agenda is. And the reason I really sort of focus on this is that if you are trying to pitch a policy idea or a reform or the value of your research to federal policymakers, that includes politicians and government officials, timing is everything and the framing is everything. So you need to know when to pitch your research to them. So things like if you've got a great idea that you think should be funded, first of all, you should find out when the budget cycle is, because that's where most great ideas are funded. And the budget generally happens at the beginning of May, but the work on the budget happens from pretty much the December beforehand. So if you suddenly think, oh, gee, I've got this great idea, I think the federal government should fund this, and you come to the minister or the department in April, it's generally too late. So that is really important, and trying to pitch what you are doing or what you're working on or what you want the government to think about in light of what they are already doing. So, for example, the government might be very focused on providing mental health services or supports through a particular program. You might have some research which is really relevant to that. So tell them how it could improve the program that it's already running. So it's trying to make it as easy as possible for government to see how it is relevant to them. Some other really sort of key things to know about the cycle of business is things like Senate committees and inquiries. They produce a lot of really, really in-depth reports on a lot of health policy topics. So if you follow the process, find out when they're calling for submissions, and you've got research that's relevant, you should make a submission. Anyone can do that. You should also find out when those reports are being released or tabled in Parliament, because that's another opportunity to highlight the research that you're doing or the work that you're doing or the clinical practice you're doing. So these kind of routine things, just become familiar with them so that you know when is the right time. The other really important point is to find out what the federal government is responsible for. A lot of the information that we receive or people come to us with good ideas is probably done by the states and territories. And so it's sometimes hard to know from the outside, sometimes hard to know from the inside, to be honest. But find out, ask. So is that what I'm working on, is this something that the federal government can influence or be interested in? If not, you can contact the states and territories about the same sort of thing. So it's just make sure you're talking to the right person. The other tip that I had for people too that are trying to influence national policy is to work through organisations that already get access to ministers and to government officials. So we are engaged with lots of different groups all the time, routinely, and they have a voice at the table, they have a seat at the table, they have a voice, they are listened to, they are heard. So it is hard for individuals to sort of get their foot in the door. So my advice is to find out who already has their foot in the door and talk to them. So, for example, on allied health, we very routinely engage with a whole range of allied health peak bodies. And so if you have research that you think is interesting, make sure you tell them about it and make sure you're involved in their processes, because we often go to them and they would then be able to say, oh, actually, we do know something about that. You know, this person's doing this fantastic program, or we found this really great research, you should know about it. So that's a really easy way to get in front of policymakers. The other one is to engage medical peaks. So again, your research may be about allied health, but there are a lot of medical peak bodies that are interested in the health system and health services more generally. And they will sometimes recognise how important allied health is as part of that team. So sometimes it's worth going beyond the allied health sector as well to try and have some influence. There are also a lot of peak bodies or non-government organisations that look at specific issues. So, for example, the National Rural Health Alliance looks at rural health, or the Obesity Coalition looks at preventive health. So a lot of those organisations would really appreciate contact from clinicians and researchers that have suggestions or ideas about how they could improve outcomes for people or improve health services as well. Another great idea is to work with research academics in allied health, so the conjoint professors in allied health, because they do have a seat at the table at the main, I guess, stakeholder meetings that we have on allied health. And we do go to them seeking information and research on best practice in a whole range of areas. And then finally, it's a great idea if your research is relevant to aged care or disability providers to go through them as well, because they also are routinely consulted by governments and their ideas are sought. So there's a few ideas about who you can work with. And then finally, if you do have some really fantastic groundbreaking research that you think is relevant to the federal government, the minister or the department, then contact us directly. There's no rule saying you can't. You absolutely can. But it's a few key tips for how you should do that. First of all, write something that's really short. And I know that is a challenge, but no more than 2 pages, and explaining what the problem is and what problem you are solving for government. So government are very interested in solving practical problems. They're not so interested in sort of theoretical issues or understanding the extent of the problem further. They want to know what they can do about it. So my advice is explain what the problem is and what the problem is for government. It might be that this costs a lot for government. It might be that there's people missing out on care. It might be that this is going to be a future problem for government if they don't do something now. Some simple things like that. But also explain to government what they would need to change and be precise about it. So look at this research and they need to make changes to this program or this funding or this policy, and this is how. It doesn't have to be detailed. Details can be worked out later, but they need to know which lever they need to pull or push in order to make a change. The other thing that's really critical is to have a go at estimating what it might cost. And that means both in financial terms, but also in political terms. So you might have some research and say, we absolutely need to do X, Y, and Z, but it's going to be a huge controversy with all of these other groups in the community. They need to know that. Doesn't mean they won't do it, but they need to know what political battles they might be getting into. And they need to know if this is going to cost $10 million or $10 billion. It's quite different, obviously. So give them some kind of information. The other things I would really suggest is, if you have got some research that you think is highly relevant, is to seek a meeting with the minister, the relevant minister or government officials. They are really interested in good ideas and better practice. They just need to know why it's relevant to them. And the other sort of less direct route is to try and get media coverage for your research. So things like, writing to the local media, getting radio and television coverage once you've finished research, or writing for the conversation, which is often leads to media coverage in its own right. And it's a great discipline, writing up your research for something like the conversation. And then finally, I just wanted to point out another opportunity to influence policymakers and make a difference is to do some training on the policymaking process and research translation, but also see if you can get some experience. So one of the things we've been doing in the Department of Health is running short-term secondment for academics, so allied health academics, to come to the department and work with us. We've done 2 so far, and they've both been a rip-roaring success. So we got lots of really great information about research in allied health that was directly relevant to what we were working on, so aged care and primary care. The researchers themselves got a huge amount out of it, understanding how government works and how they need to pitch their research to governments. And we've got these ongoing relationships now where we can say, hey, can you just give us the best information you've got on X, Y, or Z? So it's a really great to take a chance on doing those kind of things. It could be a short-term secondment. It could be a short-term job for 3 months or 6 months, or it could be permanent, but I don't want to recruit all the allied health to the department. But there are lots of ways you can find out how it works in a really productive way for both you and the government as well. So I'll leave it there, and thank you, Kathy, and I'm sorry you can't see me.
Yeah, I'm really sorry. That was awesome. Thank you, Anne-Marie. Heaps and heaps of tips. I feel like we really need a whole workshop from you, but there's so much that was very rich in the how-to, from the complicated to some very simple things, and very welcoming. So take up Anne-Marie on her offer, like for internships and things like that. Be really productive for all of us if more people did that. Thank you, Anne-Marie. And I'd now like to introduce Professor Sue Berney, who's been the manager of physiotherapy at Austin Health since 2014. She's worked in the acute care setting in tertiary healthcare for more than 30 years in Australia and internationally. And she's active in research herself. So she's a manager, leader, and a researcher. And in 2015, her department was recognised with the Premier's Award for Excellence for supporting a redesign of the acute hospital workforce. So I'm sure we're all really looking forward to that. And thank you, Sue.
Thank you, Kathy, and thank you also for the Academy for allowing me to come and speak with you today. And I'm hoping you can see the slides. So this afternoon, I thought I would speak to a number of strategies that we've initiated here in the physiotherapy department to try and build and grow research. And I hope some or any of it might be useful for other people in the audience. The first thing I think that is really super important is to have a productive partnership with the university. And by that, I mean creating an academic environment within the department, which includes taking of students. So we take physiotherapy students from 2 universities and have relationships with both universities that are important to the business that we do in the department every day. We also look for opportunities for co-supervision of research higher degree students from our staff, either on an academic level or as a clinician who is a supervisor because of their clinical activity. We also recruit for academic excellence. So what I mean by that is that we actively recruit new graduates who have an interest in completing a research higher degree, and also have the marks to successfully apply for a PhD scholarship, with the aim that the candidates remain in the physiotherapy department during their studies, so other clinicians can directly observe research practice and also contribute to the candidates' research process. And what we get from that as a department is that the PhD candidate sets an important example to the clinicians about a potential research career. And they can act as future mentors for our staff, and also assist staff in what Nick was talking about earlier, which is framing a question, a clinical question, so that you can actually get an answer. For the PhD candidate, it enables them to maintain clinical practice, and that's often dictated by in accordance with the PhD award that they've got. So they might be able to work 1 or 2 days per week. The department wins from that because the candidates are often interested in higher paid work, which is often weekend work, which other people aren't as interested in if you work as a full-time member of staff. We also, one of the things that we have made an active decision to do, which is to set expectations that research is a part of what we do every day. We have it embedded in our in every agenda meeting within the department. There is an agenda item about research, and also in people's performance review and development framework, and in their supervision. We have also made research one of the 3 key pillars within our department, along with education and a positive learning culture. And the value proposition for the staff in this is that what we believe in these 3 areas which research contributes to is taking care from being adequate to excellent. And so it's seen as and the whole department works on this together, and it's seen as being a very important piece of work that we all do together. We also, I think it's important to leverage your university relationships and gain organisational support for a funded research position. And I think once you get those types of positions, your research outputs can really exponentially grow. We were able to obtain funding for a professor of physiotherapy that was half funded from the department and half funded from the university. And the position is employed by the university, but sits most importantly in the hospital. And it's been pivotal to the success. It's enabled us to put research frameworks around quality improvement or clinical questions. And we're now much better at applying that framework at the right time, either at the beginning of a project or when feasibility has been established. And I think one of the important things is that the professor of physiotherapy works very differently to me. We sit in different meetings, but between the 2 of us, we're able to identify and leverage opportunities where we can partner and grow research within the department. We meet regularly, and I think that's an important part in maintaining the productivity around the professor position. We also have a rotation, a junior rotation that exposes staff to research. This rotation goes for 8 months, where a junior member of staff who has a potential interest in completing a research higher degree is exposed to all areas of research, from ethics applications through to collecting data and writing a manuscript. And the aim of the rotation is that each staff member gets a first author publication that assists them in the pursuit of research higher degree funding. And lastly, what we do that I think is also important is that we celebrate and recognise success. So we have an annual research symposium. We have a lecture from a prominent researcher, and we also give recognition at that time for people who have published throughout the year or completed their PhDs. And we award a prize of $500 to the staff member who has contributed to the successful research activity over the previous year. We also have publications, and prizes are recognised in our weekly newsletter. And these strategies all working together, I think, have been really critical to building a research culture within our department. And we're by no means where we want to be. We've still got a lot of work to do in our research pillar, but I think we've made important strides. And I think one of the things it was critical was in achieving an acute workforce redesign was that we were very much tied to evidence-based practice and taking our workforce to where the evidence lay. And I think that was an important part for us in being successful. So I'll stop sharing now and go back to Kathy.
Fabulous, Sue. Thank you so much. I reckon you'll be inundated with people applying for jobs with you, you and Anne-Marie. So thank you so much. It's, I'm hoping there's a lot of people registered to do this for this seminar, and I'm hoping some of them are managers in clinical environments, managers and leaders who can use some of these strategies. So many questions to ask you. And finally, I'm really delighted to introduce Associate Professor Vinicius Cavalheri, who is also a physiotherapist. It's a bit physiotherapy heavy, but actually we invited them because they're professors of allied health and broader kinds of roles. He's got over 15 years of experience in clinical research. He's the Allied Health Research Director at South Metropolitan Health Service and an Associate Professor at the Curtin School of Allied Health. His main field of research is exercise training and promotion of physical activity in people with chronic lung diseases such as lung cancer and chronic obstructive pulmonary disease. So we look forward to a few comments from you, Vin. Thank you.
Thank you very much, Kathy. And can I say that you pronounce my first name and surname perfectly? And not many people can do that. That's awesome. Thank you.
So I've done one good thing tonight. That's excellent.
That was great, Kathy. Thank you. Look, thank you so much for the invitation to participate in this session. It's a huge privilege to be part of such a great panel and talk about integrated pathways in allied health research. So this may be what a pathway for a clinician researcher career may look like for many of us. And we know there are many barriers to a clinician researcher career. And we also know that clinician researchers prefer roles that are embedded within the health service. But this very recent paper from Caitlin and Elizabeth, talked about some of those barriers for a clinician researcher career. The fact that research may not be always valued in a clinical environment, and I'm sure that's not what happens at Sue's department. And it's amazing to have heads of service like Sue. Lack of incentive for research, lack of research roles, and current challenges that impair the viability of a clinician researcher career. So there are many other barriers that we can list here. But for people who try to navigate through those barriers, and overcome some of those barriers when they engage in clinical research and they complete a research degree, it could be a master's or a PhD, what commonly happens at the end of that initial stage in the clinical research career is that they either divert to a full-time academic role that may or may not have a research component, or they go back to full-time clinical practice. Very recently, things have been changing with more opportunities for a clinician researcher career, but I think in allied health, we're in infancy stages, especially here in WA, I've got to say, but there is definitely hope. So what I'm going to be talking about now is some of the activities that have happened here at South Metropolitan Health Service in Perth, for an integrated pathway in clinical research. So we believe that a pathway for clinical research career can start at the recruitment stage. So when we're interviewing both junior and senior people for roles that we have, clinical roles, and we ask about research skills, research engagement, interest in research or evidence-based practice. So I'm not saying that this happens across all the 9 departments within our allied health service, but definitely in some of the departments. As soon as they are a new staff, they go through the new starter program in allied health, and it's managed by the allied health education director. And I've got some time there to talk about our research vision, the strategies for research, and the research support that we offer as a service. Some of those initiatives are research education and training with short video lessons, face-to-face sessions, one-on-one sessions, and research mentoring, which is driven by the service, so South Metro as a HSB. Also, opportunities to apply for protected research time, and this is part of the Building Research Capacity initiative that's supported by the Chief Allied Health Officer here in WA. And just for you to have an idea, in the past 2 years, which is the time that I've been with South Metro, we've been able to support 311 research days and 40 staff. And that's a great initiative from the Chief Allied Health Officer. Partnerships with academics, obviously, as Sue mentioned, supporting with honours, supervision, masters, PhD supervision, but also applying for grants and getting research started, but also QI projects. Interdisciplinary collaboration as well across the 9 areas. We've got some senior staff in some of the senior research staff in some of the departments, which were really helpful. And collaborations with industry as well. There's good collaboration in audiology and other departments. So in the past 2 years, we were able to offer a couple of PhD scholarships and master's scholarships, so 4 PhD scholarships and 1 master's scholarship for allied health staff to enroll in PhD and masters. And then very recently, I'm very proud to say that we've announced our inaugural postdoctoral clinical research fellow within our service, which is basically protected time to do research post PhD. And very soon we're going to be advertising for clinical research roles now within 4 different departments in our allied health service, and they're all joint positions with Curtin University. So this is what the career pathway is looking like in our service at the moment. Obviously, there are lots of things that can be added to this, and obviously we're focusing on I'm focusing my energy in other things as well to be added to that career pathway. One of them is financial reward and career progression, which obviously will make those careers more appealing. As I talk to you, there have been changes that happened now at an individual level with all those programs that we've been supporting at a team level, department level, now allied health service level, the health service provider level, but also health department level. And there's a lot of momentum towards clinical research, which is really great. But in conversations with the Chief Allied Health Officer, we realized that for financial reward, we need to engage the professional bodies and the health service unions to try to make this more attractive for a clinical research career pathway. So this is where I'll probably be focusing a lot of my energy in the next couple of months, trying to make sure that people are rewarded and have career progression within the health service. Well, I try to be very brief, and I'm more than happy to take any questions. Just would like to thank again the invitation to be here, all the partners for this collaboration between Curtin and South Metropolitan Health Service, and also say that I've learned so much from the Australian Allied Health Professors Group in the past 2 years. This group has been led by Andrew Bailey. We've put a position statement together on the value of allied health research. If you haven't had a look at that position statement, there is a QR code there. And thank you so much for your time.
Wonderful. Thank you so much, Vin. And, one thing that came through with all those, all of you, is that this is not easy. And Vin actually had there all the layers he had to navigate and negotiate with to get such a career path going in the department. Sue didn't elaborate on, I know, that a huge volume of work that she had to do to get it up and running in her department. It's kind of like, well, here we are now, and it's absolutely amazing. But I know there was a lot of work and a lot of negotiating with the powerful bodies at various levels to get it happening. So thank you. If all the panel members could reappear, that would be good. And we'll have our fingers crossed that you can, Anne-Marie, but we know that you're there, and Lauren as well. So Anne-Marie is blank, but she's there. So don't forget to put any questions in the chat. There were more than 400 registrants for this session. So I'm expecting heaps and heaps of questions. I'm going to ask the top 3 questions first of all the panel. So one of the very common ones is, I've found as a PhD student / full-time clinician, so those 2 things, that one of the major barriers to doing research is that managers higher up don't know how to support us. So this is open to all of you. We've got managers, such pathways and support. And so maybe that's gone some of the way to answering that question. But perhaps we can start with you, Lauren, to tell us what you, coming into such a role, having done your PhD, as a clinician, what would have really helped you?
Yeah, I think, thank you, Kathy. There's a few different elements of that. And I think sometimes if you have a line manager who's had less exposure to research themselves, sometimes it is just not knowing what support you need to undertake that pathway, particularly if you're one of the first people within your department to be pursuing that. So I would say some of it's looking into options that might exist within your existing framework within your health service. So often things like study leave, if you're enrolled in a postgraduate degree, can be applied for on a prorated basis in negotiation with your supervisor. So looking at those documents, having an open conversation with them about it. That was another element that I found was really helpful. Again, being full-time, letting my line manager know, I'm okay full-time at this period of time, but within, these particular months, I might need to be taking some additional leave. So providing some additional notice around that so that you can help work out what supports are required from that point of view. I also think it's really important to speak with your manager very early on if there's other elements of support that your project will require, whether that's engagement with other members of your team to assist with data collection, or what will be the expectations around the level of support that will be needed from the department more broadly. I think having an opportunity to have an open discussion about that, and that might even also involve your academic supervisors, can also help with navigating some of those processes. And ultimately, your managers have the opportunity, if they support you, you're going to be presenting that work at conferences, publishing that work, which again shows that their particular team is a centre of excellence within that particular field. So I think it's also sharing the positives for the broader service of you engaging within that.
Thanks, Lauren. Does anyone have anything to add to that? So that great advice there, but really it's a common experience for people. And if you're the manager, the managers higher up often or mostly don't actually have research backgrounds. So it's hard for them to understand. So possibly you need to try and understand better and talk to colleagues from the university where you're doing your research, where you're enrolled, and try and work out what might be the most useful things. And then I've got a question to follow up that with, but I'll get to some of these really popular questions first. And this one's really, I think this one's really important. How do we change the workplace culture of research, in inverted commas, competing with clinical work, when clinicians are in such demand and managers don't want to lose anyone? This is really, really common in most of the clinical workplaces I've worked with, that you're employed to do the clinical work and the research is kind of just a bit of an add-on. So Sue, you have changed the culture. Like all of you, feel free to comment on this, but Sue, you've actually taken the bull by the horns here.
Thanks, Kathy. I mean, it's a great question. I think one of the super important things is allied health clinicians are always busy. And when we look at the work that we do that adds value, where often there's an evidence void. And that's not to say that the practice isn't valuable, but it's very hard for us to be guided by the evidence when the evidence isn't there. And so we can get drawn into doing busy work rather than important work. And I think research is a really great pathway to use to be able to answer some of those questions about what's valuable and what's busy. And I think the sell to people outside of the department or to the manager of the department is that very point, because if we are to make a difference in, I think, taking really Anne-Marie's point, but to a very local level, is you need to understand what the drivers of, sorry. The drivers of, so for example, in Victoria at the moment, there is a massive workforce shortage, and we're finding it very hard to recruit allied health clinicians across the board. If you can make a workplace that is interesting, that's dynamic, they're the promises I think that research offers in terms of being an employer of choice and using those arguments to ensconce a research culture that not only refines the work that you do every day into doing the important work and the valuable work and not the busy work, and also enables clinicians to really act at the top of their scope, to be able to be collecting data. We have a team that have, what they actually can see every day is the number of outcome assessments that they've done. They can follow the trajectories of the patients, and that helps them make better decisions about where their resources are put. So, creating dashboards can be really useful ways of informing clinicians to make better decisions, and they will then engage in the process because it's helping them manage their workload.
Perfect. Actually, I won't I'll just throw, there's a lot of questions. So I'll just throw questions at different people because all of you are perfectly able to answer them. And some of what you were saying, Sue, relates to developing a value proposition, which Anne-Marie was also talking about, but we might end with that. So Nick, are there tested strategies that increase success of clinicians in pursuing PhDs?
Thanks, Kathy. So strategies to encourage clinicians to pursue PhDs. Yeah, it's an interesting question, because when I've asked this, what I've found is that in fact, the people who, in my personal experience, when you have to try and convince someone to do a PhD, it's never going to work. So you mustn't really, and so I've been to meetings with it. What are the strategies we can recruit PhDs? I think it's being there and having a research active organisation. And then those people, the 1 in 7 of allied health clinicians with a light in their eyes, they will find it. They will find it. So it's kind of like a bit of a contrarian view in a way, that I found when I've stopped trying so hard, that it was easier to get clinician researchers involved in research. But if I actively pursued it and tried to sell it to them, they backed off. So perhaps not the answer you wanted, Kathy, but that's been my experience.
I don't know if that'll be satisfying to the audience, but interesting. Vin, what do you suggest for clinicians who are keen to pursue research opportunities within their roles but lack the support from management?
That's a very good question, Kathy. I think collaboration is one of the things that they can pursue. And that collaboration, as I talked about in my talk, could be with people who are more senior researchers or clinical researchers. So academics, anyone within the allied health service in a different discipline to your discipline. And making sure that what you're doing as part of your research adds value to the service, adds value to your patients, adds value to the health service provider. It's very clear now, like working across 9 different disciplines, the difference that management can make to opportunities for clinicians to engage in research. And absolutely, when you have managers who are either trained in research or can clearly understand the importance of the research to the department and to the service they make to creating opportunities for the clinicians. But I think the main thing for the clinician is, what are you adding? How can you demonstrate that you're adding to that service with the research that you want to do?
Lauren, did you want to quickly add something to that?
Yes, Kathy, that just aligns with what Vin was saying. I just popped in the chat about people thinking about their elevator pitch. So how can you align what the goals are for your particular research project or area of interest with what the goals or strategic directions are of your department or the organization? So really think about the hook, which, how can you really look at how you can engage with that? And it might be, aligning with some of the broader things within the organization, but showing how you can sell that idea. And again, if you can, as Vin has suggested, look at opportunities to have external collaborators, which really show that you've got some rigor and strength behind what you're suggesting to do, that gives you a little bit more credibility as well, which can often go a long way.
Perfect. There's lots and lots of questions. Who would like to answer? Are there different options for clinicians to obtain support for HDR with an income? Scholarships, models of funding for research relevant to health service? Anything else that you can add there to support clinicians to enroll in a research degree? Sue, what other role models do you have?
That's one of the areas that we're actively pursuing at the moment with the university, and trying to use our Melbourne Academic Health Centre through the MRFF to see what we can do in terms of supporting clinician researchers. It's been done in medicine, and we're looking to do it in other areas of allied health, and also to cross-supporting through the professor and the department a stipend to support clinical practice. But that takes, you have to be able to use the money. You have to have access to that money. And we're lucky that we have a special purposes fund that we can use for that money that's not operational. And so we're looking for those. We're kind of trying to identify what those models might look like if you have an MRFF support versus someone who's unable to attract support to do a PhD. But I think really that's a big area that needs wider discussion between universities and health services about how we can support people who, particularly clinicians who've got questions that have come up. It's a long time since they've been at uni. They're not competitive for a grad, but are worthwhile supporting because they're going to stay in health. They've been in health for 10 years and they're going to stay in health. And we all need those people.
Absolutely. So none of this is easy. Yeah, Vin.
Thanks. Yeah, I agree with Sue. There has been some movement here in WA, and it started with an idea from our Dean of Research here at Curtin University within the Faculty of Health Sciences, with a collaboration between the university and the health service providers. The idea was to offer one PhD scholarship for allied health, one for nursing, one for medical. So 3 scholarships per year for 6 years. So at the end, we would have 18 scholarships. Now, the conversations have escalated now because it seems that the health department liked the idea and are trying to engage the other universities as well in that idea. And the research should be something related to the clinical practice of the applicant, and it would be done whilst they're training. So for example, obviously it started with medical research. And I remember I was the only allied health in that meeting, and I'm going, oh, are we talking about only medical research, or talking about health research here? So it was an interesting discussion, but it started with medical, providing RMOs with part-time PhD scholarships as they were going through their medical training. And then now it's sort of expanded to nursing and allied health, but it's a work in progress here in WA, and hopefully we're going to have some positive outcome very soon of those discussions. But it's basically part-time PhD scholarship and at a higher rate than the usual PhD scholarship as well. So we can sort of try to match with the salary of the clinicians.
Mm. And Lauren's put a really helpful comment in the chat. Do you want to quickly note that, Lauren?
Yes, just that for some smaller projects that funding might not necessarily be needed if you can embed it within what you're already doing within your day-to-day clinical work. So really having a think about your research question, maybe outcome measures or data that you're already routinely collecting, and how you might be able to effectively use that to help you investigate current practice or answer your particular research question. I know I've definitely had colleagues who've completed really high impact studies which were completely unfunded but related directly to what was happening in their day-to-day clinical practice. So just that it can be feasible depending on the scope and the support available in your organisation.
Fabulous, thank you. So heaps of ideas. We're a tiny bit past time, but I'd like to get you all just to think for a moment about one piece of advice you have for clinical practices attempting to implement a research program. So if you can think of that, and Anne-Marie, if you could just very briefly give us a little bit, while people are thinking about the most important piece of advice, tell you just tidy up the value proposition bit so that people know how to go with a value proposition when they're trying to convince not just a minister for for funding, but maybe to their manager to get research into the daily practice, to do something like Vin and Sue and Nick are doing, and now Lauren's doing. So if you could do that, Anne-Marie, while the others are about to tell us the one important piece of advice.
Yeah, sure. Well, I think mine's kind of one important piece of advice as well, because I've been listening to people talk about, great ideas or the research they want to do on clinical practice. But from my perspective, and I think it's the same for a state government or even a hospital manager or a clinic manager, is just remember a lot of what you could do could be rolled out. It could be expanded. And so if you can build something into your research that acknowledges that, the care that you're providing is provided in many other places across the country. And yes, things need to be tailored to the local context, but often it's not that different across large parts of Australia. So if there's something that you could build into your research that acknowledges how what you are doing is relevant to other parts of the country, and if you can partner with someone who's got some experience in health services research or health economic research, suddenly you've made what looks like a small-scale project nationally relevant. And you would be surprised how some of those really small-scale things have a huge impact. And the reason for that is because there is not a lot of funding for allied health research. So when we look for research, we are looking at those. So don't think it's insignificant. It's often the best we've got. so if you could just think about the national relevance or the statewide relevance or how it could be rolled out from the start, and it will still be really valuable to us. So thank you, Kathy.
Fabulous. Thanks, Anne-Marie. Nick.
Yeah, I think the one thing, and it's picking up a bit on what Lauren said and Sue's talk, and I think it's really important that we see research as part of practice, not separate to practice. Sue said research is part of what you do at Eastern Health. And that mindset, I think, is so important. I think it's a real, how do you get there? We'll ask Sue explain some of the ways you get there to change that viewpoint, that culture. But if you have a viewpoint that research is separate to practice and always must be backfilled, then it's not going to happen. It should be seen as part of your practice. Really important.
Vin.
It's hard to add to that. So that was great, Nick. I'll go back to what Nick said in his talk, to have a clear vision. And on top of a clear vision, a lot of enthusiasm and also a clear, well-formulated and answerable clinical question. Because, sometimes the questions are great, but may not be answerable. So a clear, well-formulated and answerable question.
And Sue?
I think that whatever you do needs to be relevant to the clinicians and the work that they do every day. So it may be down to collecting, deciding on an outcome measure that everybody's going to collect, and they're going to collect it about the same group of patients, and that they can start to see then that that it's possible, and then you can put some research framework around the fact that you've actually collected the data. And the only other thing I would say, because I couldn't really divide the two, is that you must have a university partner. It's just too hard to do without a university partner.
Perfect. And I leave the last word to our newest PhD graduate, Lauren.
Find good mentors to help support you on the journey, because it really is a team effort, and it's important to have a really strong support network.
Absolutely. And you can do things your own self just by reviewing your own clinical records. It's sometimes a really good place to start, and it doesn't need much funding or anything else. So there are many, many more questions, and I'm really sorry that we can't get to them all, including what's the definition of a clinician researcher. And I don't know that there's a single definition, so we won't go there. But thank you all very, very much. Our esteemed panel of speakers taking us on a really good journey and showing us different models of how this can actually be done. It feels when you're starting out a bit insurmountable, like no one's supporting it, but it can be done. Here are people who have done it and brought a whole lot of people along with them and had massive impact and influence far beyond their own little tiny orbit, like big impact, which is changing the shape and the visibility and the reputation and respect for allied health. So congratulations to you all on what you're doing, and thank you for sharing with this massive audience today. And to that, I'd just like to let everyone know that this has been recorded, and the recording will be up on the Academy's website at least by tomorrow, probably. I'm not quite sure, but something like that. And you now have like a bit of a community of practice. Here are people who can put you in touch with people that might help you locally. There is Anne-Marie has a whole, she's mentioned several groups that she goes to that are powerful. And Vin and Nick are both members of the Conjoint Professors Group. And I know that they would also be happy if someone reaches out and wants a bit of a pointer, and the universities are always there willing to help. So this is the start of the next phase. Like it's all started now. We have clinician researchers, we have pathways. They're not nearly universal enough. Like we need them everywhere, but they are starting and they're respected. And so there's many models that we can start to build on in our own workplaces. So thank you all the participants who I can't see for joining us, and I hope that this has been helpful. Reach out. I'm really happy as well to put you in touch with people if you want to just reach out to me. I love that kind of stuff, and I love to support people trying to make a change and take the next step. So thank you to every single one of our
really magnificent presenters and all the wonderful things that you're doing. It's very altruistic, it's very generous, and thank you. So bye everyone, have a good night.
Thanks, Kathy.
Thanks, Kathy.
Bye. Lovely to meet you, Sue.